everyone to our Cummings Graduate Institute podcast, Disruptors at Work and Integrated Care podcast. Cummings Graduate Institute is a private accredited nonprofit university that offers the Doctor of Behavioral Health program in a 100% online format. CGI is focused on moving the needle of integration forward through advanced research, education, and training, including continuing education and workforce development initiatives. Our vision is to improve the way the world experiences healthcare by raising awareness about what integration is and by sharing best practices for disrupting antiquated models of care delivery. Doctors of Behavioral Health, DBHs, are trained to design, implement, and evaluate the clinical, financial, and operational changes to care that accomplish the quadruple aim of healthcare improvement. This podcast represents discussions among subject matter experts, integrated care providers, and the patients we passionately advocate and care for. Today's episode focuses on the process of reverse integration, including the processes of accreditation for clinical practice and the operational and financial processes that it takes to prepare an outpatient behavioral health practice to transform into a fully integrated medical practice. And I'd like to introduce our guest today. We have with us Dr. Larry Ford, and he is a doctor of behavioral health who was inspired by the volumes of studies he completed on how infinitely the psyche affects the body. Dr. Ford founded Hands to Guide You as he fulfilled his doctoral studies as a DBH in November 2011. Dr. Ford centers his practice on the certainty that there is no physical health without mental health, and correspondingly, Dr. Ford has advanced Hands to Guide You as a preeminent leader in integrated care and population health. Hands to Guide You, with Dr. Ford at the helm, enjoys distinction for engendering unparalleled patient rehabilitation and recovery rates and expansive patient health literacy. Dr. Ford's expertise on the impact of chronic diseases, such as chronic obstructive pulmonary disease, COPD, depression, and anxiety on physical health, have been peer-reviewed in articles at Arizona State University in October of 2015. Dr. Ford enjoys respect from both his patients and contemporaries as an authority on decreasing excessive healthcare costs in the state of Oklahoma, which therein has significantly reduced health insurance coverage denial, due in great part to Dr. Ford's accomplishments in holistic treatments. Dr. Ford's integrated treatment has also decreased hospital readmission by 30% in Southwest Oklahoma City alone. So welcome, Dr. Ford. Thank you so much for joining us today. It's a pleasure to be talking with you.
Thanks for having me.
Absolutely. So could you begin, please, by telling us a little bit about the history of Hands to Guide You? How did you start up, and where has the road to integration led you?
Well, I started up, as you said earlier, when I was a student in the DBH program, and it was just looking back, it was truly remarkable and overwhelming, because I was able to take the information and the knowledge I was learning in school and apply it to real life settings, like on a daily, literally on a daily basis. And people don't really understand when I say on a daily basis, but literally for students and people that are interested in the DBH program, I was literally able to do this in real time. And I just slowly but surely applied all the information in real time. And, nearly a decade later, I have a integrated healthcare facility in Southwest Oklahoma City.
Mm-hmm. You've really achieved the epitome of what Dr. Nicholas Cummings imagined for the doctors of behavioral health, in the future. And he always talked about, when we were studying under him, he always talked about how healthcare will change when the doctors of behavioral health are the CEOs.
Yes.
How do you feel like that applies to you, and how did that inspire you throughout the process?
Well, it allowed me to get through many, many, many doors. Just being the decision maker and being able to talk to certain people, other decision makers, and being able to talk to them about information that they needed. And the good thing about it was they didn't even know that they needed the information, or in some cases they didn't even know where the information was or if it existed. So it just allowed me to speak their language in a different way, but also present them with information and knowledge that they weren't aware of at the time.
Mm-hmm. And that's something that, we all aspire to as doctors of behavioral health. I think there's still a little bit of fear when a person is, going through the DBH training that might hold them back. What words of wisdom do you have for our current students or for those who aspire to be a doctor of behavioral health in terms of, really putting their fear aside and getting out there and having the difficult conversations or, making those cold calls that it takes?
First, self-care, because it's a long journey and you're going to have to be motivated each and every day. Don't be weary of no's, just have your research and your information and the data and everything you need and continue to move on and have a focused population. Very early I was able to focus in and hone in on my population and just dissect the population down to, every habit that was costing the insurance money and able to present that in a professional manner to the healthcare organizations, to the insurance companies, and just having all the data and research and being able to present it and speak their language.
Mm-hmm.
What you learned in the DBH program.
Definitely, yeah. And a lot of the assignments that we do as doctors of behavioral health students lead to opportunities to share that data and information in the real world, as you said, in the same time that you're completing those assignments. Mm-hmm. And I noticed that since graduation, sometimes I call upon my skills as a student to compile data and present a proposal. Have you noticed the same thing, that you're using the same skills that helped you achieve?
Yes. I mean, the only difference is at one point I was a student and now I'm not a student anymore, but I still use the same information that was gained in the program on a daily basis. And that's one of the keys of becoming a DBH, because not only do you learn it in real life time, but you're able to apply it on a daily basis. And like I said, the only thing that's changed now is that I'm not a student, and before I was a student, but all the information and all the knowledge that I gathered as a student, it still applies to this day.
Yeah.
You just gain on it. And with the hours and hours and hours, we're looking at nearly a decade later. That's a lot of hours. And so you just hone in on your clinical skills.
Absolutely. Thank you for that. Can you tell me a little bit about what led you to decide to do reverse integration at Hands to Guide You?
It was another gap in care. In the DBH program, one that you, like Dr. Cummings always said, like he told us many, many times, you find a need and you fill it. And that boils down to a gap in care. And in doing this in behavioral health, and especially during these times of the year, but even before 2020, finding gaps, and you looking at hospitalizations and looking at readmission rates, and finding out that a majority of our patients were deemed non-compliant for a couple different reasons. One, they didn't have a primary care provider, or two, they didn't have a good relationship with them, or there was just a gap between the patient and primary care. So a way to better serve the patients that we were serving was bringing primary care with us.
Mm-hmm. Absolutely. And I think the important thing that you said there was, focusing on the interactions you were having with the patients and learning what the gaps were, and then taking the bull by the horns and addressing that yourself, rather than, bemoaning the system for not, being what it needs to be to meet patient needs. You said, okay, this is fixable. Let's go for it.
Yes. And I can tell you firsthand, on the behavioral side is different, extremely different, because every call I had to make was about primary care, because it's truly a different specialty. We're specialists as behavioral health providers, right? So primary care is another specialty. So calling the insurance company, setting up contracts, negotiating contracts, and telling them what you want to do and the plan that you have, yet I'm a behavioral health provider. Mm-hmm. So, why are you, a lot of the calls were, why are you calling? You're in behavioral health. And it was a lot of, I know, I get it, but just listen and hear me out.
Yeah.
Type conversations.
Mm-hmm. Would you say Would you say that those repetitive conversations were, very time consuming, and how long did it take you to get through to them?
Oh yes, they were very time consuming and very time consuming and at sometimes repeated. This is the conversation I just had literally 2 months ago, and I believe that was a lot of the prolonged time just because truly they didn't understand what I really wanted to do. Because if you look at the state of Oklahoma and the health disparities that we have in the state of Oklahoma, integrated care is on the way up, I should say. Being mindful and hopeful and wishful, but it's still very far behind from many other states around the country. So a behavioral health provider talking about primary care was very uncommon in the state of Oklahoma.
Yeah. And I know too that, here in the state of Arizona, there are very few truly integrated primary care with integrated behavioral health and psychiatric and case management care coordination care.
Mm-hmm.
And so I'm wondering, is it a new specialty that you have to transfer from a behavioral health specialty to an integrated care specialty, or do you just offer two specialties under one roof?
So again, this is something that I learned in the DBH program. We still have behavioral health. However, now we have primary care, and we also have behavioral health providers who have either been trained or will be trained that will be able to work in the primary care setting. Because in the DBH program, we learned how valuable the behavioral health providers are in the primary care setting. So some behavioral health providers will continue to be behavioral health providers in the traditional behavioral health model. And then some providers will do both. Well, they'll have traditional behavioral health patients that they see daily. And then on some days they'll be on the primary care side where they'll be the behavioral health consultant seeing patients on the primary care side, filling those gaps in care.
Okay. So I think it's a real benefit, in terms of what I've experienced in my own clinical practice, which, as you know, is with maternal mental health. I've been working in an integrated birth center now for the past 3 years. And what I've noticed is that I really need to clone myself at least 2 or 3 times because the need is so great. And in order to be the, epitome of the behavioral health consultant, you really need someone who's available for the warm handoffs
Yes.
and the quicker follow-ups, and then also someone who's available to do longer term outpatient behavioral health follow-ups.
Yes. And then in our population, it's different. We on the behavioral health side, we receive a lot of women's health referrals, but also on the primary care side, because we are also accredited to see the medically complex and the older adults, which we know the older adults in our country have chronic conditions, multiple chronic conditions. So now that population that doesn't have primary care providers are able to come under one roof where they already have a relationship, where they have a sense of trust, and they're able to improve their health. Earlier, you were talking about health literacy and how they're going to be able to improve their health literacy and improve their care and decrease their cost of care,
And
which
it really
is significant.
It is different, and it really does take a special practice who really understands why individuals may not, the reasons. They look for reasons behind why adherence isn't happening instead of just label a patient non-adherent.
Mm-hmm.
And I'm assuming that's a lot of the training that you've invested in your team.
Yes, daily.
So tell me a little bit about how that works. How do you find good people to bring on as behavioral health consultants or care managers, and what kind of training do you do?
First, I've learned over the years you don't find them, you have to create them. Because they're not around, they don't exist, and you just ultimately just creating them and spending a lot of time with them and training their mindset, because it truly is a shift. It's not a mental health specialty. It's not specialty mental health. It's behavioral health, which is not really same or similar. It's a lot more holistic care, and it's treating the patient, not just in the building, but treating them in the community that they live in. That's where the population health comes in. That's where the social determinants of health come in, you know, and all of those factors come in. So I literally couldn't find them. I had to create them, and
Absolutely.
still creating them.
Mm-hmm. So do you do clinical supervision on a day-to-day basis, or do you meet weekly?
Yeah, day to day.
Mm-hmm.
Day to day, I just essentially give my clinicians and providers access to me all day.
Mm-hmm.
I'm here in the office with them, so they have access to me all day. And I just expose them to many different things, many different patients, many different diagnoses and acuities, and just give them access to me all day. And they shadow me. They'll shadow me and watch me, and then vice versa. I'll watch them.
Mm-hmm. That's a great training model. I've found that it works really well in my setting as well. And it gives, gives them that extra confidence when they've been able to do shadowing with you.
Yeah.
It's not always something that happens in behavioral health training at the master's degree level. So,
Mm-hmm.
let's see. I wanted to ask you a little bit about the operational impact of going through the process of accreditation. So
Mm-hmm.
not everybody goes through CARF accreditation.
Yes.
And so tell us a little bit about what that took, from you as a CEO to accomplish that.
Many hours of work, determination, and paying attention to minute details,
Mm-hmm.
and just looking at, knowing my long-term goal and my knowing my long-term goal and my long-term plan, and just figuring out how I could get from 2011 to 2020, doing strategic plans and performance improvement plans, all of those plans. And just, I made my policies from the very beginning very futuristic, even though I knew I wasn't where I needed to be. I knew the plan and knew where I wanted to be. So I just built everything out literally many years in advance.
Yeah.
Many years in advance to be here. I was looking through one of my CARF books the other day, and I believe it was the year 2000, and I think it was the 2012 year CARF manual. And I was going through it, and you go through your books and you're looking like, what was I thinking back then, or what was I doing? And I had highlighted this integrated behavioral health in the primary care setting, and I highlighted, and I knew the policies and everything I was going to take, and that was in 2012. And yet right now it's 2020. So,
yeah.
So
definitely that intention was set early on as a DBH that you wanted to accomplish this and arrive here. How does it feel?
It feels great. It feels great, but still have many miles to go. But I do enjoy being where we're at now because it's different, and it's a significant step up. It's a significant step up because now over the years, we won quite a few awards and made a name for ourselves in the community, made ourselves available for the community, and being established on the internet, being an established organization, and actually the top organization on the south side of Oklahoma is a very huge accomplishment. But we know where the journey is, where we're headed with our journey.
Absolutely.
So this is another step up, and it's something that we're all eager and looking forward to.
Yeah, absolutely. Well, can you tell me a little bit about the outcomes that you measure, and where do you report to, or who do you feel those reports on outcomes are most valuable for?
So I have a story behind this. So
Okay.
many years ago, 2011, again, I keep referencing the DBH program, but this is just the reality and the nature of the conversation. So we learned about how to truly track measures and provide evidence-based training, the gold standard of evidence-based training, how to provide measures, how to measure our outcomes. And I literally made in the program spreadsheets, Excel spreadsheets that we currently still use and have. And we still use some of the common ones, the PHQ-9s, the GADs, you name it, we'll probably claim it. Whatever screening tool we need to use, depending on diagnosis of what we're thinking, we still use those. I remember it's 2020, so probably 2017, 18 maybe, the state of Oklahoma made it mandatory for us to track ACE scores, right? Adverse childhood experience, on all 100% of adults, and they said it had to be done. I still remember it by June 1st. Well, we had already been doing that for years before on adults and children.
That's
so
fantastic.
We didn't have to change. I still remember when they said, okay, now we want you to start, it's okay for you to start using screening tools and keeping track. They implemented that. We made absolutely no change.
Yeah.
So we've been fortunate enough to stay ahead of the curve and be ahead of the curve in our state, at least, and I believe truly around the country too. And we keep track of those on a spreadsheet. And now the technology and the EHRs are a lot more robust and help you a lot more. But initially, we started with spreadsheets, traditional spreadsheets, and keeping track of them and keeping them in the chart. So you can still, if you find one of our charts and go back to 2012 or 2013, you're going to see all those PHQ-9s and screening tools still in the chart, the ORSs and the SRSs still in the chart. And we still do that to this day. We just have a lot better EHR to help us.
Yeah, the EHR definitely helps with reporting. It makes pulling the data easier, but it takes a good EHR. Which EHR are you using?
We use a couple, and we'll be adding another one with primary care. The one we'll be going with for primary care, and eventually transforming to all is Athena Health, and it's immaculate. We like it. We're doing the training on it now, but it's very good. It tracks everything, any and everything that we want is already in the system. All the screening tools is in the system, and everything we need on the behavioral health side and the primary care side is in the system. And one of the things that I like most about Athena Health is that it has HIE, health information exchange, because now we're able to track our patients in real time. So now we know, before in the past we would have to ask them, have you been to the emergency room? Did you make your primary care doctor's appointment? But see, now, Dr. English, many years later, being involved in the community, now we have relationships with the hospitals. Now we have relationships with these providers in Oklahoma City. So now our system will be able to talk with their systems. So we'll be able to see some of that valuable information in real time. We'll be able to pull their pharmacy up in real time. So now we won't have to ask the patient what medications they're on or send a consent to the pharmacy or anything like that. We'll be able to see in real time and add that directly over to our care plan. Not so much a treatment plan, but a care plan.
Yes.
You know about.
I do. I love that. That makes me so excited. There are just so few places where patients can go where their complete record is at the fingertips of the provider. They are at point of care. That's so exciting. It's a big deal.
Yeah.
I'm excited for you.
Yeah, thank you.
Such wonderful. You're really making all of Nick Cummings' dreams come true.
Yeah, we do. Well, we definitely spend a lot of time with them.
Yes, we definitely did. Yeah. And, there's a story that I love that you told me years ago about how you used the Biodyne model with a patient who was just really resistant to adherence for the diabetes regimen. It involved having I believe it was a long sleeve T-shirt that was hanging on the wall.
Yes.
Mind telling that story?
Yes, I still have that shirt in my office here. Yes. So it was a patient that was very non-compliant, extremely non-compliant, quote unquote. And of course, when this was many years ago, and I was developing an organization and developing, who a doctor of behavioral health is and what services we can provide and how we can be efficient in this current healthcare system, right? So initial referrals were, the worst of the worst. And it was a patient who has type 2 diabetes who was not taking his medications appropriately as prescribed. He wasn't making his medications. He had some wounds that were infected to the fact of where he had needed a wound vac, which is designed to help close the wound up and heal from the inside out. And he was not even taking care of that the way he should. And, the hospital had tried everything. They talked to me about everything. And I had met with the gentleman once, and it was time for his next appointment. So, about the black box warning, excuse me, we had to be very creative and be outside of the box and be thinkers. Mm-hmm. And so I said, I have to get his attention. What can I do to get him on board? So I had different shirts in my offices for different situations. So I took a shirt and I folded it at the elbow. That's where his wound was, the elbow. I folded it at the elbow and creased it. So my whole thought process was I need him to see what his life will look like missing a limb. Mm-hmm. And it was very out of the box. And, of course, they had mixed feelings and emotions about it, but just trust me and listen to me. Mm-hmm. And even me, looking back, I was, I'm like, okay, here we go. So he comes in and I close the door and he immediately sees the shirt because I put his chair where he had to look at the shirt. Mm-hmm. He said, oh, is that for me? No, that's not for you. That's for a patient that had severe diabetes that's non-compliant, which is nothing like you. That's for somebody else. And we continued the conversation, but the whole time he was visualizing this shirt. He asked me a couple times if it was for him. No, it's not for you. Remember, I told you that's for a patient that's non-compliant, who's not following doctor's order, and he lost his arm due to these reasons. And we went on, and that was enough for him to get it and buy on. And that's, that was what it took for him to visualize it and see and say, you know what? That's not where I want to be, and that's not what I want to do. And then he realized that he had some other underlying issues with depression, anxiety, and some other behavioral health issues that was trumping his physical health issues. And that allowed me to open the door and treat him for his behavioral health concerns, which led to the improvement of his overall health. Mm-hmm.
I love that story, Dr. Ford, because you didn't give up on that patient. It was a lot of times, I think, with traditional healthcare provider training, we are taught, well, you can't save them all. Mm-hmm. And so there's this expectation that we have that, there comes a point where it's on the person, but a DBH is taught to go that extra mile, to think outside of the box, to get really creative from the psychological perspective and think about, what is it, like you said, that they're not able to visualize, that I can bring into reality for them to help get over this resistance? We're taught a lot about working with the resistance. Yes. And I love that story because you really illustrate there how, you took your compassion and your I'm not giving up on you, for this patient, and you really helped move beyond and helped him identify what was underlying, what was going on with the non-compliant, perspective that the healthcare provider saw. So thank you for sharing that story. It's one of my favorites.
Oh, you're very welcome. Thank you.
Yeah. So I'm wondering.
Put that shirt in my office Hall of Fame or something. I still have it here in the office.
I would love to see that. Yeah.
But he didn't have any more readmissions after that.
And what a success story, I mean, how many providers can say that they took a person from near to having a limb removed, to no hospital admissions after that? That's a huge, huge deal. So mm-hmm. I'm wondering too, if you're seeing some more patients during, the pandemic who are really struggling with management because of the additional load, that allostatic load of social isolation, and, just having difficulty with healthcare access, having to do telehealth is not easy for everybody. We did school online. So, for us, it's something a little bit more natural. But tell me a little bit about anything that you've observed during the pandemic that's harder for patients, and how is your team addressing that?
Diligently. We've seen it in waves. So initially, it was more of the depression, the anxiety, the fear of the unknown, not knowing what's going on. Because you got to remember, we see a very sick population. So it was the fear of the unknown. I don't want to get sick. So their anxiety levels was through the roof, and their depression began to climb and escalate, right? That was initially. Then we had a wave to where we started seeing a lot of professionals. A lot were healthcare workers, and some were just professionals that were continuing to work, and the stressors that they were dealing with and everything they were going through on a professional level, and then going home, having concerns about going home and transferring something, and making their family safe. And now, during this section that we're in, especially with school. So now you have to remember, school has been out for roughly 7 or 8 months. Some schools are going back. Some schools have transitioned to online, which in many ways hasn't been a success for a large majority of our state and the country. So now we're seeing a lot of kids, and now kids and their family members, parents, moms, dads, or caregivers, or whoever they live with, because now they spend a lot of time with each other. And then now you add school with this time. And then I think a lot of people underestimated everything that goes into school and education and training, and making sure that your child doesn't get left behind. So now we're seeing those stressors, a lot of children, a lot of adults, from that standpoint. And it's just continuing to change. So we've actually seen 3 or 4 different waves of patients.
Yeah. It's so interesting that you refer to those as waves, because that's definitely what I've, kind of seen as well. I just hadn't envisioned it as the behavioral health waves of the pandemic. A lot of times we hear about, oh, the second wave is coming, and that's the, increasing rate of, case rates of COVID, positive rates, once people get back to school and business. But what we've seen in behavioral health is lots of waves of those issues that you identified. And, certainly I have a child who's, remote online learning from home. And, I'm a busy professional, both clinically and, I also run a university, I run CGI, and, trying to stay on top of it has definitely created a definite new mental load on both myself and my husband. We're seeing it. And I imagine, just like with the patients that I see, primarily mothers, many of them are birthing during a time where they have to go to the hospital alone, or, with only, one partner or caregiver, instead of being able to have, a sister and a mom and a doula present, for example. And then in the postpartum, people aren't doing meal trains anymore because they're afraid that the food that they make at home might infect the new mom and her family. And, so those ways that we take care of new moms after they give birth have completely changed. The game is different now. And, so I'm definitely seeing a huge increase in the rate of anxiety. In fact, a recent study from Motherly, which is an online magazine aimed at moms, they did a study recently, and they showed that pre-pandemic anxiety rates in the population of moms was around 29%. And during the pandemic, the study was published in May, the rate was anxiety at 72%. And the rate of depression had gone from around 15% to around 41%. So we know, and we are measuring, that behavioral health need increase. And, definitely, like you mentioned, it takes a really good team. But I'm also noticing that healthcare providers are becoming more and more burned out. And so, like you mentioned, healthcare providers are worried about getting sick and taking that illness home to their own families. So what are some of the things that Hands to Guide You is doing to support your own providers during this time? And what do you see that has been working?
SelfCare. self-care, and like I explained, self-care looks different for any and everybody. And self-care is just something, as you know, that adds to you and doesn't take away. So whatever you can do when you're not at work consistently on a routine basis, that's going to add to you is something that I encourage all my staff members to do on a daily, consistent basis. Because even with nothing going on, we have very stressful careers and we have a lot going on, and we're required to be fully charged each and every day. So
Yes.
we have to, the same principles that we use for our cell phones and tablets and iPads and surfaces, where we like to keep them fully charged and we know where that charger is 100% of the time throughout the day. We also have to know what our self-care plan is and how we preserve ourselves and how we can go get a charge. And that charge might look like, taking a walk around the block, around our medical complex, a couple times a day, just to say, you know what, I have a quick 15 or 20 minutes. I'm gonna spend it walking around the block and just charging my battery, because they depend on us. We're servants of the community, and that, it's our job to keep the community safe. So self-care, self-care, self-care. Anything that adds to you and can charge you up.
I love the two things you mentioned. One is thinking about self-care, like, where am I going to get that charge? I know where my phone charger is. I know where my laptop charger is. I know where my iPad charger is, but where's my self charger? I love that idea. That's so visual. And I also love the example that you gave, because a lot of times people think self-care means a day at the spa, but not only is that expensive, it also takes a day out of the life. But the problem with most people's lives is that there isn't enough dosing of self-care. There isn't enough recharge. Like you mentioned with that, you have to charge your phone up several times throughout the day and then at the end of the day. So where are you going to find that charge? That doesn't mean you leave your life to do it. You need small 5 to 15-minute doses of self-care, whether it's a walk around the block. Like I love to do that when the weather's nice here in Phoenix. In Oklahoma City, I assume, during good times of the year when it's maybe not raining, or too hot or humid, you're taking that walk outside the building just to get outside, get some natural vitamin D, some sunlight, do some deep breathing, maybe just clear your head so that you can come back and not be so burned to a crisp when you meet with that next person.
Yes. And I gave that analogy, very intentional, because in 2020, we literally, know where every outlet is. We know where all our chargers are, and we have chargers spread throughout the office. We have outlets spread throughout the office so we can charge our devices, right? Well, with me, I have self-care models all throughout my life to, I have an app that we use here in the office. It's called I Am. It's a positive affirmation app that sends me positive affirmations throughout the day. That helps. I may go outside and take a walk around, or I may come upstairs into my office and just do 5 minutes of meditation with some nice, good, deep breathing, relaxation. So just like we have chargers spread throughout the building, I also have self-care plans spread throughout my day.
I love that idea. The librarian, Lori Christensen at Cummings Graduate Institute, had put some physical activity recommendations around our office, as a joke, but also because we were talking about, needing a self-care plan. And so I love that idea of placing reminders throughout the office. But one of the things I think is really important is your support of that at the CEO level. And if we are not, as the leaders of our healthcare organizations, if we are not consistently checking in with our staff to ask, how are you today as a human? Not, are you ready to go? But are you okay as a human? Is there anything you need from me as your leader? And, are you taking time off as needed? Are you taking good care of yourself nutritionally? Are you getting good sleep? Are you getting some physical activity in your day? Are you drinking enough water? Are you checking in with your own primary care provider as needed? And do you need your own behavioral health supports? We encourage all of that at CGI on a regular basis to our staff, our faculty, and our students, because it's critical. Just like you said, you have to have those charges available to you throughout your office and throughout your life.
Yes, it doesn't work any other way.
No, and especially not during a pandemic and an election year, and during a time where people are just being assaulted by so many negative inputs throughout the day, all day.
Yes, I agree.
Yeah. Well, I'd love for you to share with me the app that you use. Did you say it's called I Am?
Yes, I am.
Okay.
It's IAM. It's a
Okay.
positive affirmation app, and it even has different settings. They have a free version and a paid version. I believe the paid version is around $19.99 for the year. Which
that's less than a behavioral health appointment.
Yes,
Okay.
yes, which is, and we actually prescribe that in our appointments for a majority of our patients that we see. But it's I Am. It's a positive affirmation app, and I have, me personally, I have it programmed to where different self-care, stress and anxiety. It's different categories you can use. So from this time of the day, you can focus. I have it set on more focus-driven affirmations. I will get this done. I'm ahead of the task. I stay focused on the task at hand. And you say them, you hear them, and you store them.
Yes.
So it's a wonderful app.
I love that idea. And that's another strategy I love that you use with your patients. I definitely use prescription of smartphone apps with my patients as well. I make sure that I've, looked at them and that they're an app that I know the cost, if there is a cost involved, and that, I understand how it works so that I can share with them exactly how it works. And I've had some patients tell me that the use of something like the Calm app with sleep stories has helped them to resolve insomnia. During, early pandemic, a lot of people were experiencing difficulties with sleeping, and they were, having problems with insomnia. And instead of looking for another medication to add into the mix, we're looking for how can we use, an app to help you get back to sleep if you wake up too early or in the middle of the night. And we're seeing some really good results with that too. So I'm excited to hear we're both using that strategy.
Yes. And Calm is another good app that we prescribe also. We have a list of them that we prescribe for many different reasons that help. Insomnia is a big problem. Stress and anxiety is a big problem. Depression is a big problem. And, just keeping them motivated and keeping them going throughout the day is a major concern. And, most people carry their phone everywhere they go. Years ago, we had many, we called them, they were folders, but we called them toolboxes. And we fill their toolbox up with all these different sheets and these tools to help them. And now we're like, how can we be innovative? Where DBHs are innovative.
Absolutely.
We make a living off being innovative. So how can we continue to be innovative and stay innovative? And we said they have a device on them 100% of the time for the most part. So how can we make the most of this device for them?
How can we put ourselves in their pocket?
Yes, exactly.
Yeah, I love that strategy. It's so helpful. One of the other tools that I've learned to use is the behavioral health prescription pad. I created a template on Vistaprint, and I created little prescription pads. And as we talk, I'll write down, 2 or 3 suggestions, and then I give it to them, and then I keep the carbon copy for their notes. So the next time I see them, I can check in with them on how did it work? Were there any barriers? And then we can work through that as well.
There you go.
Yep, we can be pretty creative when we put our minds to it. Yeah. Well, I guess my final question to you would be, if another behavioral health practice or if another, primary care practice were considering integration or reverse integration, what recommendations would you have for them? Are there any toolkits or resources or websites that they should be looking at? Or, what words of wisdom do you have to share?
Find the DBH.
No kidding.
Yeah, find the DBH.
Absolutely.
Find the DBH and have your specialty population that you want to serve and treat, and find a DBH who's an expert in that field of study. And
have that DBH lead them through the process.
Yes, because it's going to be challenges on both sides. but with the knowledge of a DBH, it just makes things a lot easier. Not just because you have to understand, Dr. English, we're not just speaking clinically. If we were speaking clinical and what you had to do clinical, it would be a lot easier and a lot more people will be able to do it. But we have to get so much past clinical, being a clinician in everything that we do on a daily basis, being a CEO, having to go to executive meetings, having to run a business and an organization, manage a budget, continue to have plans, our strategic plans and hire. And now it's all about duplicating, like I was saying earlier. When you asked me, how did I find the people? And I said, you can't find them, you have to create them.
You have to grow them.
Yeah, you have to create them and grow them. And you have to walk, you have to nurture them and really take care of them and create them.
Mm-hmm. Well, and I think that's a big difference with a DBH as well is the care. It's not just that you're training them and then sending them off without you being the support network. You're really there to help. Yes. You're really there to support. And it's that, that culture that you're building, that, spirit of I'm asking you to do hard things, but I'm not going to ask you to do anything that I wouldn't do or haven't done myself. And I support you. I've got your back too.
And you're going to see me here doing it every day next to you.
Yep. That's huge. That speaks volumes. Yeah. Absolutely. Yeah. All right, Dr. Ford. Well, thank you so much for your time today. It's been a great conversation as always. I think we could probably talk all day if we wanted to. We have many times. Yeah. And so I'd love to invite you back to the podcast again to talk about many other subjects. I think we've just barely scratched the surface today.
Yes, I would love to be here.
Great. All right. Well, thanks again for all of you who are out there listening, and we'll be back with another episode of Disruptive Innovation very soon. Thanks for joining us. Bye-bye.